So I'm here with Mike, who's a respiratory therapist, and I've got some questions I want to ask him. How you doing, Mike?
Good, how are you?
Good, thanks. So, the first question I want to know is, how do I know when a patient needs to be intubated?
Well, there's a few ways to find out if a patient needs to be intubated. One of the main ways is just by looking at the patient himself. Increased work of breathing, tachycardia. Another way is to assess by ABG. If they're acidotic, then that's another reason to be intubated.
One of their pulse ox is like 88%. Is that a reason?
It could be. A good reason to be intubated is the patient's having problems ventilating. So if the blood gas is acidotic, then the ventilator can help fix that. But if someone's pulse ox is just low, you could use other modes of oxygen delivery to raise their pulse.
So what other modes? Can I use BiPAP to bridge them to intubation or something else?
Sometimes BiPAP is able to help ward off someone being intubated. It helps decrease the work of breathing, helps them ventilate better, as well as improve oxygenation. But sometimes it's not enough and it's necessary. So.
Can I use it in everybody? Let's say I just don't want to intubate somebody. Can I just put BiPAP on it? It's the same thing, right?
As CPAP? Or
no, as being intubated.
So having the breathing tube down into the lungs gives us more control over their minute ventilation and respiratory rate. Pretty much we have entire control over their breathing. So a BiPAP, they still are able to breathe on their own, and the BiPAP is there just to help a little bit as opposed to the ventilator doing most of the work. So.
And what do those settings mean? I always get like 20/5 or something. 20/5 is it?
20/5 is a pretty high setting, so we usually start out 10/5, and that is a CPAP of 10 over a CPAP of 5. So the patient, when they inspire, the machine will give them a breath up to a CPAP of 10, and when they expire, it will keep them at a CPAP of 5. So an elevated baseline, and you assess with an ABG. If they're still hypercarbic, then you can increase the IPAP. The IPAP is that higher CPAP level.
So if it was a 10 and they're still hypercarbic, then I can go to 15?
Right, yeah, go to 15. That pretty much helps them get a bigger tidal volume, exhale more CO2.
Okay. But it doesn't give them breath, so if the patient's not breathing, then clearly BiPAP's not a good...
Yeah, that's the main thing. If the patient is not breathing, BiPAP isn't the best option, but it can breathe for them to an extent. But then you have to deal with leaking around and just issues with the patient's lung compliance. They could have real stiff lungs that could require intubation.
What about an NG tube or a Delpop? Does that preclude using BiPAP?
That is one of the main causes of leaks with that tube. There's no real way to avoid that at all. So you have to compensate by increasing the IPAP to help get them more volume.
If he is intubated, what are the common modes that we use for ventilating them?
So the most common mode that we use when intubating someone is called assist control, and that is a mode where you use volume, and every breath the patient gets is a set volume, and that is based on their height. So it's morbidly obese. You don't go by their weight, it's always by their height. And that mode does all the breathing for the patient. You can have a set rate, so if someone has a set rate of 12 on the ventilator, they will get 12 breaths, but they can also breathe over that set rate, so they're not locked in, but they're always going to get that 500 or whatever their tidal volume is.
Is it uncomfortable?
It can be if the patient's awake and the set tidal volume isn't enough, then they will start to set off the alarm on the ventilator. They have what's called breath stacking. Auto peeping can ensue if they are uncomfortable. And if they do overbreathe and start double breath stacking, double clutching it's also called, we can switch them to a mode called pressure support, which is much more comfortable for a patient that's awake. This mode is a spontaneous mode of ventilation. The patient does a lot of the breathing on their own. We use it to wean patients off the ventilator. and there's different levels of pressure support from real low to high. You know, we just try to make sure the patient's comfortable and synchronous with the ventilator. So.
Okay. And stop. So you mentioned auto peeping. What does that mean?
So auto peeping is also known as air trapping. For intubated patients, they usually have trouble exhaling completely. This is most commonly found in patients with obstructive airway disease, such as COPD. One way to limit auto peeping is to decrease the respiratory rate. That gives them more time to exhale fully. You can also administer bronchodilators through the ventilator to help relax the smooth muscles in the airway.
Can you sedate them? Would that help?
Sedating also helps. If they're desynchronous with the ventilator, by sedating them, you have more control over their airway and how they breathe. So.
Excellent. And what is that minute ventilation? What does that mean?
So a minute ventilation is how much air the patient's moving in and out in a minute. A good easy calculation to use is the respiratory rate times the tidal volume. And the ventilator usually automatically calculates the minute ventilation. A normal minute ventilation is 6. So if someone is breathing over 12 breaths a minute, it's called hyperventilation. And this could be for a number of reasons. They're in pain or hyperthermic, just for example. And then if someone's breathing less than 6 liters a minute, that's called hypocapnia. And this could be due to oversedation or just uptoneness and lethargy from retaining CO2. So, just for example.
Okay. So I've heard about a recruiting maneuver. What does that mean?
Indeed. Recruiting maneuver is a maneuver that we do on the ventilator.